We are now going to be talking about the issue of trauma during pregnancy, which is actually a very common thing that we run into in this age group, as you can imagine. And so we're going to be having a review on trauma in pregnancy by Dr. Devon Smith, who is also on the UCSF faculty.
Thank you very much. So transitioning now to folks who are scheduled for their surgical procedures to a group of patients who are decidedly unscheduled. So as Joy was mentioning, I am on faculty at UCSF, but I have the privilege of working predominantly at San Francisco General Hospital, which is the only level 1 trauma center in our relatively large city. So I'm commonly placed at the confluence between pregnant patients and patients who have suffered a recent trauma. My goal today, I'd like to provide you with what I would consider a practical primer for how to understand and approach what can be very challenging patients. I'm too young to have any disclosures. So again, our goals. Over the next 25 minutes or so, first we'll briefly touch on the epidemiology of trauma in pregnancy, including the most common mechanisms and the surprisingly large burden that this represents in our trauma population. Next, and most importantly, I'd say we'll work through ATLS and really touching on the few caveats that are specific to the pregnant patient. I've dedicated a few slides to what I would consider one of the points in this process that can turn into a little bit of a bumpy ride, and that's imaging in the pregnant patient who has suffered a recent trauma. And then lastly, I'll talk about crisis management in the trauma bay, particularly the ideas of maternal arrest and perimortem C-section. And then we'll quickly review the EAST guidelines, which I consider to be the most robust set of guidelines out on this particular topic. So what I found is that this is a relatively untapped portion of our field. It has not been studied extensively yet. And I would say that one of the maybe positive things that will come out of transitioning to ICD-10 coding will be this new distinction being made between maternal death that is related to pregnancy-related causes to this new term, which will be pregnancy-related death, and that will specifically target patients who die while pregnant but who are dying for accidental or incidental causes that are unrelated to the pregnant state. I would say the most commonly found statistics are presented here from a recent review by INEV. Upwards of 7% of all pregnancies are affected by trauma, which is, when you consider that there are upwards of 4 million deliveries every year in the United States, that's about 300,000 patients presenting to the emergency department with some degree of trauma. Now, as you can see here, most patients are not admitted for that trauma, so the spectrum is quite broad. But for patients who are admitted, the most common mechanisms are motor vehicle accidents, falls. Unfortunately, domestic violence represents a large portion of this group, and then penetrating trauma as well. So parsing this into blunt trauma and then penetrating trauma. So motor vehicle accidents represent approximately 50% of all comers in this trauma and pregnancy population, and that works out to an incidence of about 200 cases per 100,000 pregnancies. The major risk factors for adverse outcomes in this group are, interestingly, improper use of seatbelts and also intoxicants being on board at the time of the accident. So if you think about this mechanistically, it's interesting. So the uterus is accelerating rapidly, obviously, at the time of the accident, but also the patient folding, particularly when a shoulder harness is not used, increases abdominal pressure significantly. So the combination of increased abdominal pressure and the shear forces on the uterus lead to what we see most commonly in terms of injury pattern, which is placental abruption. Upwards of 40% of these patients who end up being hospitalized for their motor vehicle accidents have a placental abruption. So that needs to be very high in your differential when these patients enter the trauma bay. Next, we have falls. So contributing factors here for a group, upwards of 1 in 4 pregnant patients fall during their pregnancy, which is really astoundingly high. So the things that contribute to that are increased joint laxity, which increases throughout gestation, also weight gain, and then decreased dynamic postural stability, particularly in the 3rd trimester. And in this group, placental abruption, again, is disproportionately represented here, so an 8-fold increase in those who are hospitalized. upwards of a 4-fold increase in preterm labor and a 2-fold increase in fetal heart rate or fetal distress. And then quickly, domestic violence. I think that this is a topic that we certainly can't ignore. Patients will present with blunt trauma, and they may not divulge the mechanism initially. So we really need to be cognizant of what group is truly at risk for domestic violence during pregnancy. And there are a few factors. So substance abuse during pregnancy, low socioeconomic status, low maternal education levels, and a history of domestic violence outside of pregnancy, and also unwanted pregnancies. So in these groups, when they present, it's really important, once you've triaged them and treated their trauma appropriately, that they get the appropriate social work interaction, as you want to make sure that their discharge is safe, and that they're also appropriately screened for things that occur more commonly in this group, like antenatal and postpartum depression. So penetrating trauma, these numbers are coming from a retrospective analysis of about 300 pregnant trauma patients. Obviously, as we see here, blunt trauma is disproportionately represented. It's about a 10-fold increase relative to the penetrating trauma group. But also, we see disproportionately maternal mortality is increased significantly in penetrating trauma, as is fetal mortality, almost 7-fold increase in fetal mortality in the penetrating group, with handgun violence being represented at about a 3-to-1 relationship to knife violence. So transitioning now from the epidemiology into the who's, the where's, and the how's of taking care of these pregnant trauma victims. So we should begin at the beginning, and that is, how do we decide who's going to be triaged to a level 1 trauma center? So typically gestational age is the point of reference here, and approximately 20 weeks gestation is the criteria that EMS will use to transport these patients to a level 1 trauma center. Now, what is an interesting topic here, sort of buried within, is what is the response going to look like when a pregnant patient comes in? Obviously, as I mentioned, there's a wide spectrum. So there's the patient who fell down two stairs and is relatively stable versus the patient who's been in a significant motor vehicle crash with unstable vitals. Now, should the same group attend that patient immediately upon entry into the trauma bay, our practice at San Francisco General is that there is a split here. So while pregnancy alone will activate a trauma team, it's not the same level necessarily. So we still do look at mechanism. Any penetrating trauma certainly gets sort of the full group effort, and then unstable vital signs. And I think that that's very reasonable. I'm the type of person who feels like I'd rather walk away with a smile on my face that this patient is, surprisingly stable, wonderful, rather than be called late to what can be a very chaotic scene. And I think that, minutes and seconds matter in trauma patients, so I think I'd rather be overcalled than undercalled. So this is sort of a snapshot of our most recent data from 2014. You'll see here, as I mentioned, so 33 traumas with that relatively even split between what we call our 900 level activations, which is the highest priority, versus, again, a second-tier group of patients who don't have those mitigating factors like vital sign abnormalities and particular mechanisms. And as you can see, we also had one blunt trauma victim who did have a maternal arrest in the trauma bay and a perimortem C-section. And I'll talk through this at length when we discuss ATLS, but I really think that the things that led to a positive outcome for this patient, so both mom and baby both walked away healthy, was really a concerted effort, great communication, great teamwork, and simulation, and we'll get to that later. So ATLS in pregnancy, if there's a take-home point from my talk today, it is the first bullet point here, which is essentially that the best initial treatment for the fetus is the provision of optimal resuscitation of the mother and early assessment of that baby. It comes down to the point that if you're doing the right things for mom, then the baby will follow. What we find is that fetal mortality is intimately tied to maternal mortality, obviously, and so if you're doing the right thing by mom, you're probably going to be doing the right thing for the baby. Now, what can happen, unfortunately, is that we're bringing different providers into the trauma bay. So we certainly need our obstetricians there, particularly during the secondary survey, and their expertise when we get into things like perimortem cesarean delivery is really critical. But I would say that if you ask most providers who attend these traumas, you're focused on the fact that this is a pregnant patient. You're focused on the differences, and I would say that you need to be focused much more on the similarities between trauma patients rather than the differences. So in terms of anatomic considerations, in the first trimester, obviously, the fetus is primarily contained in the pelvis and protected by the bony elements, and also the relatively thick-walled uterus. As the second and third trimester progress, obviously the uterus gradually thins, the baby and the uterus become the most prominent element and the most anterior element in the abdominal cavity, which is why they become much more prone to injury. It also changes a few other things when we think about injury patterns in these patients. So in the second and third trimester, we've displaced the abdominal contents more cephalad, actually to the point that they are more protected by the rib cage. We're also creating a buffer between the patient and any retroperitoneal damage, and so these patients do suffer different injuries with common mechanisms. I'll also just take a moment. I think that anyone who responds to trauma sees a patient who's hemodynamically unstable without maybe obvious injuries. We always think about places where that patient could be losing blood or it's difficult to identify. Things like long bone fractures, particularly femur fractures. We think about retroperitoneal injuries. And we think about scalp lacerations as injuries that are hard to quantify blood loss. And I'd make the case, particularly as I mentioned, with how often placental abruption occurs, that the uteroplacental unit needs to be a place where you expect that this patient could be bleeding profusely, leading to hemodynamic compromise. So in terms of the primary survey, I think we've had wonderful speakers that walked us through how to deal with the difficult airway that is the pregnant airway. I think what I'd like to mention about this is that, again, if you work in a trauma center, you need to be as aware of the limitations of your environment when you're down in the trauma bay as you are in the operating room. You need to be facile with all the equipment that's there, and again, know what things may and may not be available to you there. I would argue that it's actually a wonderful place for difficult airway because of the amount of trauma surgical presence there. And so if you do find yourself with an extremely challenging airway, you do have a helping hand, which can be incredibly helpful. So in terms of the breathing component, obviously these patients need to have supplemental oxygen on immediately when they enter the trauma bay. If they are intubated, I think we're all aware of the physiologic changes of pregnancy and that we need to be targeting what is a normal PaCO2 for them. Titrating PEEP can be a difficult thing, particularly in the hemodynamically unstable patient, and you need to do so judiciously. I can't remember the last time I placed a chest tube, but you may be the person in that room who is most knowledgeable about the anatomic changes associated with pregnancy, and chest tubes do need to be placed at a higher location, particularly in the second and third trimester for these patients. So in regards to circulation, I'll take a quick moment here to talk about what I think is the ideal access for these patients. Obviously, if you have a 70-kilogram woman who rolls in and you can get wonderful peripheral access, that's great, that's perfect. But in the patient who's challenging, I would say that the most common point of central access in the trauma bay is the femoral line. And I would say that that's not ideal in these patients, that lines need to go above the diaphragm. And so this is a place where we can be of considerable help. I would say that subclavian lines are wonderful, particularly when these patients come in C-collars, and they should probably be the first choice for central access. Now, in the patient who's extremely difficult, we commonly place IOs in our facility, and I can count on more than one hand the number of times they've bailed me out in a difficult situation. I would also say that I predominantly place them in the tibia, and so it's important that we become facile with placing them in the humeral head, as again, I would say that that is the ideal placement for intraosseous access in these patients. Positioning is critical. I think, again, one of our first instincts as OB anesthesiologists is to displace the uterus. There are a couple ways you can do that in the trauma bay. You can place a few blankets underneath the backboard, and I think that works fairly well. but also usually there's no shortage of hands in a trauma bay, and so being able to assign someone the role of manually displacing the uterus in a hemodynamically unstable patient, I think can be quite advantageous. So in terms of the secondary survey, and this is where the unique skill set of the obstetrician should be brought to bear. Obviously, as we are doing our first head-to-toe assessment of this patient, they're going to want to run right in and do their part, and that's critical. But again, we need to triage them, and it needs to come towards the end of the secondary survey. Now, what's their role? They should be doing a pelvic exam, looking for signs of bleeding, a dilated cervix, signs of preterm labor, but they also need to be assessing the baby. And so that brings me to my next slide, fetal heart rate monitoring in the trauma bay. So I would argue that this is an area that has twofold utility. Obviously, there's the assessment of the fetus and the relative stability, but I would also argue that fetal heart rate monitoring can be an early warning system for patients who are transitioning towards the shock state. And we know that pregnant patients are primed and more able to lose blood and not show us that they have lost a considerable volume. But the baby, again, may show signs of instability before the mother does. And so I find that invaluable in the pregnant patient who's presenting with trauma. Now, the second portion of this slide is really talking about a patient who has had a relatively less severe trauma, and we're talking about discharge. So when is the appropriate time to do so? Now, there's some varying time frames here that are proposed by both ACOG and other groups. And so somewhere between 4 to 8 hours is probably appropriate, but they need to meet a few criteria. First, they need to be contracting less often than once every 10 minutes. The fetal heart rate tracing needs to be otherwise reassuring, and the mother needs to be without abdominal pain or vaginal bleeding. And what's the reasoning there? And when they've looked at data looking at late placental abruption, the groups that did not demonstrate this late placental abruption all met the criteria that I've described for you there. So again, we're looking to prevent that. So fetal maternal hemorrhage, when I'm thinking about sending labs for these patients, again, I'm treating them just like everyone else with this one caveat. Fetal maternal hemorrhage can complicate upwards of 10 to 30% of maternal traumas. And so sending off a KB test is really a prudent thing to do. It's not helpful in terms of predicting outcomes for either the baby or the mom, but obviously it leads to timely treatment in patients who it's necessary to give RhoGAM and prevent Rh isoimmunization. So the ultrasound machine has become as ubiquitous in our trauma bays as the pulse oximeter has. It has numerous advantages, particularly for the diagnosis of abdominal injuries without the use of ionizing radiation, iodinated contrast, and also it allows you to have excellent diagnostic capabilities without the need to transport those patients. Obviously, anytime you have to package that patient up, go to the CT scanner, you're increasing that level of risk. And so it's a wonderful tool. But my question was, is it a wonderful tool in the pregnant patient? So this was a retrospective review of results of all consecutive emergency blunt trauma activations where ultrasound was used. And this was over an 8-year period. They looked at 2,300 examinations performed on women between 10 and 50 years old. In that group, they had identified a little over 300 pregnant patients. And in that group, they had 23 who sustained intra-abdominal injuries that were confirmed either by surgery or subsequent CT scan. And what they found was that the sensitivity, it looks fairly good at 61% versus the non-pregnant group where the sensitivity was 71%. And the specificity also was quite good at 95% versus 97% in the non-pregnant group. And when you parse it further and you look at this, unfortunately, it starts to degrade in its utility as you progress in gestational age. So it remains very good in the first trimester at 90% sensitivity and then decreases significantly in the second and third trimester. Also, your rate of false positives also increases in the second and third trimester as free fluid in the pelvis is quite common in that group. And what I would say is that I think there's still utility for this exam, particularly if it's grossly positive. You can skip that CT evaluation and go directly up to the trauma suite and the trauma OR. And so I think it probably should be done, but we need to recognize the limitations of this examination. So in terms of other imaging modalities in trauma patients, I think, again, as I mentioned sort of in my opening, this can be a really sticky point. Both trauma surgeons and radiologists become concerned about the quantity of radiation that the fetus is exposed to. And again, I think if we hearken back to that main point, that if you save the mom, you save the baby. And so if you think that this diagnostic imaging is necessary to appropriately triage this patient or treat them surgically subsequently, then it needs to be done. Now, when they looked at retrospective data and fetal outcomes, what they found was that anything less than 5 rads is not associated with an increased risk of anomalies, pregnancy loss, or growth restriction. And again, this represents a point where significant delays can sort of impart themselves in this process. So if you look at this list of very common imaging procedures, the only one that we start to raise our eyebrows at is the CT abdomen and pelvis, obviously, and yet still that's approximately 2.5 rads of radiation, which falls well underneath the 5 rad cutoff that we've defined. So in terms of ACLS in pregnancy, there was a wonderful retrospective analysis by Jill Meyer that came out in 2014 in anesthesiology, and it looked at the years from 1998 to 2011 and a cohort of about 57 million deliveries. Now, of that group, there are approximately 5,000 maternal arrests, and trauma played a role in approximately 2.5% of that group. And again, this is another place where I'm not going to dive deep into this. I think it's a topic all in itself, obviously, but you need to proceed as you typically would. And so if you're presented with a maternal arrest in the trauma bay, you need to proceed with ACLS with a few caveats as quickly as possible, because again, I think time is the most critical portion here. There's always some concern over defibrillation in the setting of fetal monitors, fetal scalp electrodes, et cetera, if that's necessary. And again, my argument is that the utility of progressing quickly is probably the most important thing. Resuscitation drugs, types, and doses are all the same in pregnant and non-pregnant patients. And what I would direct you to is the SOAP consensus statement regarding ACLS in pregnancy. I think it's a phenomenal tool. Over the next few slides, I just have a few figures and excerpts from that consensus statement. And I'm a big believer in checklists, particularly in what can be a very chaotic situation. And so I would suggest that these few figures and checklists are probably things that should be close at hand if you're someone who's responding, particularly outside of L&D, to traumas. And so I'm going to breeze through these in the interest of time, but there's a few on maternal cardiac arrest. So the next topic here is perimortem cesarean delivery. Obviously, we've set some pretty rigorous guidelines here and time constraints as well. And this is part of the reason why I think it's so important that we activate our traumas with a full team, including obstetricians, to the trauma bay. If we're going to meet our goals of starting a perimortem cesarean delivery within 4 minutes, we can't be calling for them once we, as the primary responding team, has assessed this patient as being critically ill and potentially needing a perimortem cesarean delivery. So they need to be brought down up front. In our case that I mentioned in 2014, I think that having the obstetrician there as part of the primary responding team was really critical in having a good outcome. When we think about the equipment that's necessary, it's actually quite small. Most obstetricians will tell you that they just need some betadine and a scalpel, and that's all that was necessary, and I really think that it was very important in saving her life. Now, this is distinct from emergency cesarean delivery. And the way I think about this, I kind of make an analogy to the ED thoracotomy. Patients who are potentially, who may potentially need ED thoracotomies need to have vital signs on the premises, on the campus, where they're not eligible, as we know that outcomes are quite poor. I think the same thing goes for emergent cesarean delivery in trauma patients. I think we can all imagine situations where, unfortunately, the fetus may have died prior to arriving, And we need to consider the morbidity and potential mortality in a patient who's recently suffered trauma, trying to save a fetus that may not be savable. So I think that it's important that the fetus is viable by local gestational criteria in terms of gestational age, that fetal heart tones are present at some point in the trauma bay, and that they then subsequently develop fetal distress. And then on a case-by-case basis, you need to be determining where the appropriate place is for the surgery to take place. I would argue there are very few instances where a crash C-section needs to happen in the trauma bay in a mother who's otherwise stable. I think you typically have time to progress either to the main ORs or to the L&D ORs. So serving as my summary slides here, I've included the EAST Practice Management Guidelines. Now the EAST group is the Eastern Association for Surgery and Trauma. And this is, as I mentioned, the most robust set of guidelines dealing with this particular population in trauma. So you'll recognize some of the points from my talk, hopefully most. There unfortunately are no level 1 recommendations. And as I mentioned, I think that this is a field that's ripe for study. Level 2 recommendations begin with the fact that all patients who are greater than 20 weeks gestation who suffer trauma should have that cardiotocographic monitoring, as I mentioned. They're a little bit more conservative, and they say for a minimum of 6 hours. They also go on to mention that the KB test is an analysis that should be performed in all pregnant patients who are greater than 12 weeks of gestation. They also, finally, starting with level 3 recommendations, they mention what I think is the take-home, again, from my talk, which is that what is best for the mother is almost invariably best for the fetus. Now, they also mention that all female patients of childbearing age should get a beta HCG test, interesting reference to Joy's talk, and that they should be shielded from x-rays whenever possible. And then at this point, again, they go in and they talk about, I think they're trying to assuage our fears about radiation exposure for the baby and how that might derail our process of diagnostic imaging in these patients. They hit again on the exposure of less than 5 rads being a critical determining point for fetal anomalies or pregnancy loss, and that it's otherwise deemed to be safe. They touch on the fact that ultrasound can be utilized in these patients and can help quite well in the diagnosis in the trauma bay, and that you should be bringing on other patients, or other providers such as radiologists and OBGYNs in a timely fashion. I think I'll stop there. I look forward to your questions, and I appreciate you having me. Thanks.